Okay, everyone. So welcome to our DYAD Seminar. So a few things about the seminar series before we get started. So the DYAD Seminar is designed to highlight the work of both the student and the faculty member. The unique element or aspect of it is that it is a presentation, that's a joint presentation of a faculty mentor and a mentee. And so what we want to do is to demonstrate the learning, the work itself, and the lessons learned, if you will, from having this type of relationship, particularly here in our College of Public Health and in the public health field in general. And so today we have a really good example of this good working relationship. We have Dr. Stacy W. Smallwood, and we have Ms. Tanya E. Jules, who will be speaking to us today about their joint work on HIV, titled Where Do We Go From Here? Advancing HIV Prevention, Treatment, and Advocacy in Rural Areas. And there is a little bit of background for each of these presenters, but I'll let them share with you what they think is important to the presentation today. So again, welcome to the presentation, and I will turn it over to our guest speakers. The floor is yours. Or I should say the screen is yours.
All right, well, good afternoon, everyone. It is a pleasure to share space with you. I am Dr. Stacy Smallwood. I am an associate professor here in the Department of Health Policy and Community Health. I am in my 8th year here at Georgia Southern and part of the Jiann-Ping College of Public Health.
And hello, everyone. My name is Tanya E. Jules. I am in my 2nd year as a Doctor of Public Health student. I am specifically on the community health behavior track, and I've been working closely with Dr. Smallwood for the past almost 2 years since I've been here. Okay. And I'll go ahead and share my screen, and we will go ahead and get started. All right, so thank you, everyone. As Dr. Telfair stated, we will be going over our presentation, discussing a bit of our work in HIV. Our title, Where Do We Go From Here? Advancing HIV Prevention, Treatment, and Advocacy in Rural Areas. A bit of an overview before we get started. Again, thank you all for joining us. And during our time together, we'll be discussing HIV in the space of treatment, prevention, and advocacy. We'll get started by talking about some of the work that we've done, specifically around Project PrEP, the Southeast Health District Wellness Center Needs Assessment, Rural HIV Research and Training Conference, and the Rural HIV Providers Perspective Study. Then we'll wrap it up with some future directions and next steps.
Thank you, Tanya. So we wanted to frame today's discussion around the words of Dr. Martin Luther King Jr. While we commonly think about him in terms of his I Have a Dream speech, he was so much more prolific and prophetic than that. And some of the words that he shared are still painfully relevant right now. So we have a quote here that identifies that of all the forms of inequality, injustice in healthcare is the most shocking and inhuman. And so in Martin Luther King's work, Where Do We Go From Here? Chaos or Community? This was one of his final books that was published before he was assassinated. And he was very prescient in terms of warning of the persistence of discrimination and the demand for structural changes that could generate new challenges and resistance. And nowhere in fewer spaces do we see that as prevalent as we do in terms of the work around HIV. And so as we go through this talk, we want to think about his words and how he encouraged us to believe and adopt the idea that our entire society must turn towards justice in order for all of us to be able to be free. And that includes justice in terms of jobs, wages, housing, education, and in this case, healthcare. And so now I want to give a little bit of context as to the specifics of HIV and what kind of guides us into the work that Tanya and I have been doing. To give some background about HIV in the US, there are currently about 1.2 million people living with HIV in the United States. Now, we have seen gradual declines in diagnosis rates over the years. Some years ago, we were up around 60,000 new diagnoses a year. We are now down to about 37,000 new diagnoses. So that is progress. However, it's also important to note that there are a number of people who are living with HIV in the US who are unaware of their status. So we can't simply rely on diagnoses because that underestimates the true incidence of HIV in the US. Now, those new diagnoses are not uniformly distributed across all groups within the population. So for example, African Americans account for 13% of the US population, but in terms of new diagnoses in 2018, we accounted for 42% of new cases. We also see that there are disparities in terms of exposure category and sexual identity. And so we saw that in same year, 2018, that 65%, almost 2/3 of new male HIV infections were the result of male-male sexual contact. So we see disparities in terms of race, we see disparities in terms of sexual identity, but then we also see disparities in terms of geography. And so this next slide will show how the different rates of HIV diagnosis across the United States as of 2018, which is the latest year for which we have these infographics and these diagrams. And so here we see that the deeper shades of purple indicate higher rates of diagnosis. And as with many other health disparities that we commonly encounter in public health, we see significantly higher rates among the states that constitute the US South. And for those of us who are here in Georgia, we see that Georgia has one of the highest individual state rates within the entire nation. Another way that we can look at that is not just through rates of diagnosis, but also through lifetime risk of diagnosis. So this infographic shows the lifetime risk of HIV diagnosis by state. And so overall, we see that, again, the highest lifetime risk of diagnosis is found within the US South. In Georgia, it's estimated that 1 in 51 residents of Georgia will become diagnosed with HIV within their lifetime. Similarly, with some of our neighboring states, 1 in 86 South Carolina residents will become diagnosed, 1 in 54 Florida residents. And so we compare to some of the states that you see in the West and the Midwest, which have much lower lifetime risk of diagnosis. So we see this geographic pattern across the states, but then we can also then look at it in terms of urban versus rural. So when we go to the next slide, we see the percentages of diagnoses based not just on region of the US, but also the population of the area of residence. So keep in mind, in 2018, we had about 37,000 new infections. The South had 19,000 of those new diagnoses. So not only does the South bear the burden of disproportionate impact in general, but you can also look at where those diagnoses are coming from. So not only does the South have more diagnoses than any other region, but there's also a higher proportion of those diagnoses taking place in suburban and rural areas than, for example, the Northeast or the West, which calls attention to the fact that we must be aware of and must be working on HIV in rural areas, especially in the South. And so it's into this context that we introduce this sweeping federal plan that has been designed to help us get to zero. So we're going to talk a little bit now about ending the HIV epidemic, a plan for America. Ending the HIV epidemic was initiated by the federal government in 2019 and has been looked at as a coordinated response between several different agencies within the Department of Health and Human Services, including CDC, HRSA, NIH, Indian Health Services, SAMHSA. In the fiscal year 21 budget, $404 million were allocated for ending the epidemic. In the FY22 budget, that number was raised to about $670 million. And so what is the money being allocated for? What is it that we're expected to do in order to achieve this goal of 75% reduction in new HIV infections by 2025 and at least a 90% reduction by 2030? How do we achieve that? There are 4 key ending the HIV epidemic strategies that have been put forth as part of this initiative. Number 1, diagnose all people living with HIV as early as possible. Through the advances that we have made with antiretroviral treatments, it is possible for people living with HIV to achieve what we call viral suppression, which means that the number of copies of HIV in their body is so low that it is virtually impossible for them to be able to transmit HIV to someone else, while also improving their own quality of life. So some of you may be familiar with the term undetectable equals untransmittable. Well, undetectable refers to viral suppression. So if you are virally suppressed, then it drastically reduces your ability to transmit HIV to someone else. Also, along with that, once you're diagnosed, we need to make sure that people are treated in order to help them achieve viral suppression as quickly as possible. There was a time when people might be diagnosed and they might hold off on starting antiretrovirals, but now the current guidance suggests that anyone who's diagnosed with HIV needs to start antiretrovirals in order to help achieve viral suppression as quickly as possible. The third point in the plan is to prevent new HIV transmissions by using proven interventions such as pre-exposure prophylaxis or PrEP and syringe services programs. Now, PrEP was considered to be a game changer. Initially approved by the FDA in July of 2012, it's a once-a-day pill that, if taken consistently, can reduce the risk of becoming infected with HIV following an exposure by 90% or more. Now, I'm saying, referring to that in the past tense, because as of just a couple of months ago, a new form of PrEP, long-acting injectable PrEP, was just approved, which is basically a shot that you can receive once every 2 months that also does the same kind of work to prevent you from becoming infected with HIV should you be exposed. And then the final point in the plan is to respond quickly to HIV outbreaks in order to get needed prevention and treatment services to people who need them. So these are the main components of this comprehensive federal plan. But I also want to encourage us today to think about this question: who's missing? We have these great tools that can really be the quote unquote game changers that proponents want them to be, but only if they are getting to the people who need them the most and getting to the people who are the most vulnerable. And there's an argument to be made that we might not be doing that as effectively as we need to just yet. For example, when we look at the areas or the jurisdictions that have been approved as phase 1 priority jurisdictions for ending the HIV epidemic, these are the 57 areas that have been fast-tracked as phase 1, meaning that these are where the resources are going first. Now, this includes 50 jurisdictions that account for more than half of new diagnoses. So those are the dots that you see, oftentimes around significant urban areas, metropolitan centers. But then there are also 7 states that were included that had substantial rural diagnoses. Now, substantial is a very nebulous term that we don't necessarily have a whole lot of definition around as of yet, but I want to call attention to where we are to point out that while there are many southern states that are included, there are also many southern states that are not being included, as well as looking at where we are in Georgia. So if we look at HIV in Georgia, we need to think about it as not just an urban story. Oftentimes when I'm giving talks about HIV throughout the state, and I ask people if they think that they have a problem around HIV in their area, they'll say, oh, no, that's an Atlanta thing. That's an urban issue. We don't have to worry about that. But what we find is that in Georgia, HIV is prevalent both in and outside the Metro Atlanta area. So if we look at where Atlanta is, right? We just circled on this map where the Metro Atlanta area is. And yes, we do see the darker shades of red indicate higher prevalence. However, if we look at where we are as part of Georgia Southern Statesboro campus in the Southeast Health District, we also have substantial prevalence of HIV in rural areas. And as you can see, it is spread across the state. So it is not just an urban story. And the factors that contribute to that HIV vulnerability are a combination of social determinants of health and environmental factors, including poverty, lack of education, lack of healthcare access, stigma, which we'll talk about more in more detail shortly, racism and homophobia, as well as substance abuse and mental health. So let's do a deeper dive on this area. The Southeast Health District in Georgia is a 16-county health district that spans almost 6,000 square miles. So we're talking about a lot of real estate. It is primarily rural. The largest city is the one where our Statesboro campus is located. But we have more than 1,200 people living with HIV in this primarily rural area. In addition to the number of people living with HIV in our area, which is continuing to grow, we also have limited infrastructure. We currently have 2 full-time Ryan White clinics, which are part of the HIV safety net, right? They are the providers of last resort. And we have 2 part-time satellite clinics, which just reopened because they had been closed during the COVID pandemic. We used to have a community-based organization in this region that did HIV testing and housing opportunities for people living with HIV, but they've had to since close their doors within the past few years. And so we have lost that rich part of our HIV infrastructure that was doing so much. And also in talking about PrEP as the game changer, just as we've seen that HIV rates are significantly higher or disproportionately higher within the South, we also see that PrEP is not making it to the people that are most in need of it or who could most benefit from it. So this infographic shows the PrEP to need ratio. So the number of people who are on PrEP compared to the number of people who were diagnosed with HIV. And so we want to actually see that number as high as possible, but you see that the South has the lowest PrEP to need ratio of any region in the United States. And we also know how rural the South is. And so we have all kinds of overlays of poverty and discrimination and disadvantage and lack of access that create the storm that keeps HIV moving. And so it is into this space that we want to now talk about some of the initiatives that we have been part of in terms of prevention, treatment, and advocacy. So I'll start with the prevention and practice, and then I'll turn it over to Tanya to talk about treatment. But I want to talk about Project PrEP, which was a community health education initiative that we started out of Georgia Southern some years ago. So a little bit about the background of Project PrEP. Project PrEP grew out of some dissertation work that I did as part of the Sexual Health in Faith Traditions study, where I was looking at the relationships between religiosity, internalized homonegativity or homophobia, and sexual behaviors. And so based on some of the results of that study, as I was transitioning into South Georgia, I wanted to start a conversation with community partners who were doing the work down here to find out, well, what is happening that is preventing PrEP from being taken up within this region? And so many of the conversations centered around 2 main themes. One was a lack of knowledge about PrEP among people who were indicated for it, or people who could benefit from it, as well as limited prevention resources in general. Again, Ryan White clinics are not funded to be able to do any kind of prevention work. They're funded to provide treatment. And so their ability to do any kind of community advocacy is very limited. And so I received a grant from Gilead Sciences to do a pilot program to create a PrEP education program for South Georgia. The 2 goals of Project PrEP were to increase knowledge and awareness about PrEP among individuals who were at high risk of infection, with a focus on MSM, or men who have sex with men, in South Georgia. And we framed this message around empowerment, this idea of taking control of your sexual health. And then the second objective was to look at relationships between psychosocial factors and willingness to take PrEP among MSM in South Georgia. We recognize that even as we look at our current COVID landscape, when it comes to biomedical interventions, we cannot use an if you build it, they will come mentality. We have to also look at the social and behavioral factors that have a bearing on whether or not people will take up the biomedical interventions. So a little bit about our approach, and I'm excited that one of the former graduate assistants who worked on Project PrEP is joining us, Dr. Ann Odusanya. I'm very glad to see you on the call. But our team consisted of a community member, a member of the MSM community who was our project coordinator, and our graduate assistants. We did heavy recruitment through social media and community partners, again, because in the rural South, we do not have a lot of LGBTQ infrastructure in terms of community centers or resource centers. And so a lot of the ways in which people build community is through digital networks. And so we developed a short interactive education session for MSM that focused on 3 questions. What is PrEP? Who is eligible? And how is it accessed? And we evaluated this using a 1-group pre-test, post-test design. And we also made sure that all of our materials were vetted by a community advisory board made up of MSM and service providers who live and work right here in South Georgia. So during the course of Project PrEP, we conducted these education sessions in a number of places. You can see that we definitely covered a lot of territory in terms of going across South Georgia, from Columbus down to Valdosta to Savannah. You will see one star that is off the map, and that is because someone in Jacksonville, Florida, found out about the work that we were doing and invited us to come and actually do some educational work down there. It's anytime that you're doing community work, it is vital that you acknowledge and give credit to the community partners without whom this work could not have gone forward. And so as you can see from this particular slide, we had a variety of community partners who worked with us to make Project PrEP work, including faith-based organizations, community-based organizations, federally qualified health centers, our Department of Public Health, and even colleges and universities across the region. So here you see some photos of Project PrEP in action. In addition to doing the educational sessions, we often would table at different events or for different fairs in order to help increase awareness about PrEP, not just among MSM, but also amongst the general population. And so you see some photos of Abraham, Anne, Julia, Javier, the students who were the lifeblood of this particular project. So I just want to give a few brief sample characteristics and some of the preliminary findings. We are in the process of writing our manuscript to summarize Project PrEP and the results. But when it comes to the MSM that we interacted with, almost 3/4 of them had already heard of PrEP prior to engaging with us. However, PrEP use was actually very low. Only 6% reported that they had ever used PrEP. We asked about their sexual behaviors. About 1/3 of them reported inconsistent condom use as either the receptive or insertive partner in the past 3 months, indicating that they would be excellent candidates for PrEP. Also, 1/3 of them reported using alcohol before or during sex, and 10% or 11% reported using drugs before or during sex. We did see that there was a statistically significant increase in knowledge about PrEP from pre to post during our education session, so we were happy to see that. However, we did not see any significant changes in willingness to take PrEP or willingness to use condoms while using PrEP, partly because we started with such a high level because we measured those on a scale of 1 to 5. And so there was kind of a ceiling effect. We didn't have a whole lot more room to go with starting at a 4.03 or 4.15. In terms of the psychosocial variables that we examined, we looked at PrEP self-efficacy, your confidence in your ability to use PrEP correctly, condom use self-efficacy, your confidence in your ability to use condoms correctly, internalized homophobia, sexual sensation seeking, and propensity to trust. And we really wanted to include that one because the thought was, if there is mistrust of the people who are part of your community from which your sexual partners are also coming, would that play a role in your willingness to take PrEP. So that's why we felt it was important for us to assess that particular factor. And what you see here is that we have moderate levels of PrEP self-efficacy, low levels of internalized homonegativity on average, moderate propensity to trust, and moderate sensation seeking. We also did see very high confidence in their ability to use condoms. And so when we started looking at the data, we found that internalized homonegativity was negatively associated with condom use and PrEP use self-efficacy. So as the higher their internalized homophobia, the lower their self-efficacy. The number of sexual partners was correlated with higher sexual sensation seeking and also mobile app use. Again, digital spaces are commonly used to identify both social and sexual network partners. And so we found that the more mobile apps that were used, the larger the number of sexual partners. But then when we looked at the psychosocial factors, we found that PrEP self-efficacy was the one psychosocial factor we looked at that was associated with an increased willingness to use PrEP. So that indicates to us that in our future PrEP education efforts, we really need to talk about how to make sure that those who are indicated for PrEP are confident that they can use it correctly and use it consistently. So now I'm going to turn it over to Tanya, who will talk about, whereas I've been talking about prevention, she's going to talk about some of the work that we've done around HIV treatment and practice.
Thank you, Dr. Smallwood. So I'll be going over the work that we've been doing with the Southeast Health Districts, their wellness centers, specifically their needs assessment. Before going into the demographics of our data collection, I wanted to give a brief background about some of the reason why we did the work we did and how it came about. So we administered an anonymous client satisfaction survey as well as an anonymous staff satisfaction survey to 2 of the 4 sites at the Southeast Health District. As Dr. Smallwood said previously, there are 2 satellite sites. However, those were closed due to COVID. We distributed printed surveys to the clients upon arrival within the waiting room, and staff received their surveys electronically. At the conclusion of data collection, both surveys were entered into the SPSS software for data cleaning and analysis. Now, talking about some of the demographics that we received, the total number of participants that participated were 184, and the mean age of those was 45. And of those who participated, 53% were male and 35% were female. 62.5% of the participants were Black and 20.7% were white. Of those, a total of 85% identified as being non-Hispanic or Latino. And to give a bit more context of the data collection period, we started from November 2021 and concluded collection in February of 2022. The data that we received specific to education showcased a varied level of education across all participants, with most participants reported having completed a high school level of education or receiving a GED. When looking at employment, half of respondents reported that they were not employed, with a little more than half of those being unemployed and reported receiving disability benefits. We also wanted to assess where the clients are receiving most of their services, and it was split pretty evenly between Bullock and Coffee wellness centers. We also wanted to assess the amount of time that clients had been receiving services at their respective locations, and about 26.6% of respondents received their services for about 1 to 5 years, and 42% had been receiving services for more than 5 years. It's also important to note the travel time from home to their care site. As Dr. Smallwood previously stated, these sites are located in rural areas, and the questions around location were specifically very important to us in understanding the context of HIV in the context of it being a rural health issue. We noticed that participants mostly had a travel time of about 31 minutes to an hour, and 16.8 reported of having a travel time of 15 to 30 minutes. This survey also included questions around the cultural competency of the staff. Overall, clients reported high levels of satisfaction from the staff, with more than 90% of survey respondents stating that they were very satisfied with the amount of time that they spent with staff, the availability that staff had to answer their questions related to HIV, and the overall services that they received. Staff's knowledge of HIV information also ranked highly amongst the clients who received services at both Bullock and Coffee Wellness Centers. Most survey respondents stated that they did not rate any of the clinic staff low in terms of the staff's understanding of HIV services and information for the clients. Almost all respondents stated that they would recommend the services at the Wellness Center to their friends who may have similar needs. The survey also asked questions for the participants about their enrollment to care. Only 16% of participants waited to begin their care after receiving an HIV positive test result. We wanted to understand some of the main reasons for delay of care amongst participants. The highest ranking was not knowing where to go after receiving their positive HIV result, and other results that the participants stated were as due to embarrassment or shame of their newly HIV status, fear, not ready to receive the care, denial of their HIV status, or fear of their friends and family finding out of their newly HIV status. And before transitioning to the next slide, it's important to note that the Southeast Health District has been conducting surveys and around their quality of care to their clients for quite some time. This is Dr. Smallwood's third time partnering, and the results have remained relatively consistent since his starting of the survey in 2015.
Thank you, Tanya. And so now, as we begin to transition to the final section, we're going to talk about HIV advocacy in action. And I just want to highlight a couple of initiatives that I hope that many of you may be interested in partnering with in terms of how we continue to keep rural HIV issues at the forefront of our HIV policy and our HIV education and health promotion efforts. And so I want to root this next part of the conversation within a particular initiative called the Rural HIV Research and Training Conference. This conference was founded by Georgia Southern Professor Emerita, Dr. Faith Parks, who was in the College of Education, and she saw a need to convene HIV prevention advocates, clinicians, and other stakeholders in rural areas to come together to share the most up-to-date information about what's happening nationally as well as regionally, and provide space to build community among those who are practicing in terms of rural HIV prevention and treatment in rural areas. And so we are actually coming up on our 10th anniversary of the conference. And so we're really excited that the conference has been able to continue. While it was normally held in Savannah, once the COVID pandemic began, we pivoted to develop a virtual conference. And so we are actually working on our 10th anniversary as we speak. But out of that conference, we actually had some research that has been generated that has helped to inform new research directions. And just to speak to my own experience, I primarily have worked in terms of community, working with the populations that are the most vulnerable to HIV infection. This is a new thing for me to pivot into the world of HIV workforce. I have done some work with that with some of my colleagues who are on the call, Dr. Mace, Dr. Hansen, but it was important for us to look at the experiences of those who are doing the work and being able to give voice to what they need in order to sustain in doing this difficult yet vital work. And so far we just had a publication on courtesy stigma and self-care practices among rural HIV healthcare providers. Courtesy stigma is also known as stigma by association, which basically means the same kinds of stigmas and discrimination that people living with HIV face, that's often also applied to people who work in HIV. Right. And so, whether they are living with HIV or not, just because they work in the space, those things also convey. So we wanted to examine their experiences with courtesy stigma and how it impacts their work. We're also working right now on a manuscript around the myths and misinformation. Go back. Myths and misinformation. So interestingly enough, we have these 2022 tools of like PrEP, syringe service programs, but we're still battling a mentality around HIV that's still rooted in the 1980s and 1990s. And so it has been interesting to see how, especially in rural areas, those old myths about how HIV is transmitted and who gets it still persist to this day. So there's still, again, a lot of social and behavioral work that needs to happen alongside the biomedical. But we don't also just want this to be completely focused on deficits or needs, because we also recognize the strengths and the assets that are part of the rural HIV workforce. And so we have some data that we've collected around compassion satisfaction as well. What is it that motivates you to do this work in the face of the odds that you are encountering? So we're excited to be able to disseminate those findings over the next few months. And also, this is a really exciting time for me because we are launching a rural HIV providers perspectives survey. And so this survey is going to go to both clinical and non-clinical HIV professionals working in rural areas to ask questions about their mental health during COVID, looking at the changes that they have had to make to their service provision during COVID, including their use of telehealth, but also looking at workforce engagement and burnout, right? How stretched thin have the members of this workforce been, and how can we better support them to continue to do their work? And this paper, while not specific to rural areas, still has grave implications for the work that is done around HIV prevention, treatment, and advocacy in rural areas. So I had the honor of working with a number of current and former executive directors from HIV community-based organizations to call attention to the structural inequities that impact their ability to provide the services that their communities need. So we started by acknowledging the history and the value of CBOs in addressing the epidemic. CBOs were the first ones on the ground. Our response to HIV has largely been driven by community advocacy and activism. And so it is important for us to acknowledge that history and those contributions. But at the same time, we also have to acknowledge that the landscape, the institutional landscape around HIV has not been favorable to the viability and sustainability of CBOs. And some of those threats have been financial. Smaller CBOs may not have the staff power or the institutional knowledge to be able to apply for larger grants, or may even be shut out of the eligibility for larger grants in favor of larger, more corporate kinds of nonprofits or federally qualified health centers or community health centers who may have higher capacity. It's also difficult to increase that capacity if resources are not provided for CBO employees to gain the knowledge, the skills, and the attributes that they need in order to continue advancing HIV in their respective communities. Leadership and governance is another issue. This especially impacts rural areas. Imagine how difficult it is to recruit board members or board chairs or solicit financial donations when you are an HIV CBO working in a rural area in which stigma is still at extremely high levels. And then there are also organizational biases, particularly among those who provide funding and resources. The idea that the smaller CBOs, because they don't think they have what it takes in order to do the work, they will skew that funding or those resources in favor of those larger organizations. And then the larger organizations basically will subcontract with the smaller CBOs to do community outreach or community engagement, right? So leveraging the relationships and the cachet that the CBOs have in their respective communities, but not properly compensating or remunerating them for the work and the labor that they are performing. And so in this particular paper, we call attention to these inequities and also provide a list of solutions that we think will help to overcome these inequities. And so as we close with future directions and next steps, where do we go from here, right? We started this framing it around Dr. King's words. And so in a practical sense, some of the ways in which we can go forward in terms of rural HIV include an expanded rural HIV research agenda that focuses on PrEP education for diverse communities, not just MSM, but especially for women of color who may not even know that PrEP is something that is available and an option for them. We need to focus on strategies to increase PrEP access, right? So PrEP is not just about access to the medication. Along with that also comes regular HIV testing, lab work that needs to be done to make sure that liver and kidney functions are not being impaired by the use of PrEP. And that costs money. And that requires access to healthcare. So what can we do to help increase PrEP access in rural areas? We also need to look at capacity building for people living with HIV in rural areas to be able to work in clinics, to work in service organizations, but also as a way to engage them in advocacy within their respective communities and their jurisdictions. And I think that there's a connection here between the capacity building and patient-centered outcomes research. Does engagement in advocacy or this capacity building, could that potentially help to have an impact on the quality of care that is received, as well as the health outcomes related to people living with HIV? We also need to look at additional support for the rural HIV provider workforce. As I've mentioned before, we need to advance complementary behavioral and biomedical efforts to get to zero. In other words, we can't just come up with the medication and use an if we build it, they will come mentality. Along with that hardware, we also need the software that comes along with social and behavioral science to help us really advance these efforts. And finally, we need more community advocacy to shift the social determinants of health and what Celeste Watkins-Hayes refers to as the injuries of inequality, or the wounds that result from structural inequities. And so in closing, and as we get ready to go to Q&A, we want to close with this quote. This is where we are. Where do we go from here? First, we must massively assert our dignity and worth. We must stand up amidst a system that still oppresses us and develop an unassailable and majestic sense of values. Now, while Dr. King may have been speaking this in relationship to the issues related to class and race in our society, we also have to recognize that HIV also fits into this particular fabric. We have to recognize HIV as a social justice issue. The lines of vulnerability for HIV infection follow many of the lines of social inequities that we have been in increased conversation around in our popular discourse, especially over the past few years. So we have to recognize that we have the tools, but we also must have the willingness to use them, particularly to serve the most invisibilized and make sure that everyone has the ability to access the care that they need, especially those who are living in rural areas.
Okay. That was excellent. Thank you, Dr. Smallwood and Ms. Jules. So if you could do the unshare so we could see everybody's screen. There we go. Okay. So questions. All right, I'll start off with the first question. Since this is a DYAD presentation, my question to both you, Dr. Smallwood, and Ms. Jules, is can talk a little bit about the mentor-mentee relationship in regards to how that works for the two of you, what lessons you have learned in the process.
Sure, I'll go ahead and go first. It's been absolutely amazing working with Dr. Smallwood. He has extensive knowledge, obviously, in the space of HIV. And I've really appreciated the inclusion in practice and research and advocacy, not just focusing on one area and really translating the experiences from one to another, really through the lens of a community effort. It's always important when working with communities that communities are involved and put at the forefront. And that essentially is the premise of Dr. Smallwood's work. And it's been really great to see that included again in research, practice, and advocacy, and ensuring that the voices of those that need the help are heard.
So
Thank you, Tanya. And if I could just add to that really quickly, Dr. Telfair, I would like to also emphasize that this has been a bi-directional learning opportunity, because although what we presented today has largely been around the work that we've done in HIV, because that's been the preponderance of my work, Tanya also brings a wealth of information and a wealth of experience in many other areas that have also helped to inform the work that we're doing. So, for example, Tanya has a lot of experience with youth violence prevention, and so working in a different realm, but also using some of those same community engagement skills has allowed for cross-pollination for us to be able to learn from each other and share with each other. And it's helped to enhance the work that both of us are doing, both together and within our respective spaces.
Apologies for interrupting. So, Ms. Jules, in particular, what, as a doctoral student, what is it that you yourself have learned in regards to not just the practice stuff, because you are pretty experienced yourself there, but in terms of just conducting the research, communicating the research, those sort of things. How has growth, if at all, has happened in that direction?
Yes, that I remember meeting with Dr. Smallwood before even starting the semester in an interview that he said wasn't an interview, but it definitely was an interview. And I remember specifically saying, research is not my area of expertise. I am not good in that space. The only experience that I've done is community-based participatory research. But in terms of, literature reviews and analyzing the data in, various, SPSS or SAS and going on that front, that it was not my area at all. So I was very much nervous when seeing not only Dr. Smallwood's CV and the work that he's done, but really understanding what it means to be a researcher. I was really nervous in entering the space, but I've been supported in various ways, whether it was intentionally or not, whether it was, working on how to ensure that my reference lists are actually meeting APA standards, the very fine details, or again, really combing through the data until, reaching saturation to a point where I can assess moving forward what gaps in the literature are present and how to include my perspective from a non-biased scientist, how fair I understand, to come to a result that made the most sense for the population at hand.
Okay, thank you. So Dr. Smallwood, sort of the other side of the question. So when you encountered Ms. Jules and you gave her the talk, or as she's interpreted, the interview, and then you sort of circle back to her, what were your goals for things you wanted her to kind of get out of this relationship? I know it's ongoing, but clearly, like you said, there's a mutual relationship, and I'm glad that you're saying that. However, but you must have some goals, aims, so forth, that you really wanted that to happen in this mutual relationship.
Absolutely. Thank you for that question. It's difficult for me to answer it without also mentioning some of the students that I've had the opportunity to work with, past and present, right? So I mentioned that Dr. Odusanya was on the call earlier, my first graduate assistant when I got here. And I've, so many students, even some of them are on the call right now that I'm working with, maybe not in a GA capacity, but in more of a research collaborative and mentorship capacity. One of the biggest things that I always want to bring into a collaboration with a student is making sure that the student is getting something out of the experience. I have seen, not here at previous institutions where I've been, I've seen examples of where particularly doctoral students or graduate students are used to produce information that helps to contribute to manuscripts, for example, or to grant applications, but no credit is given and there's no real explanation as to why we're doing what we're doing. So it is important for me to make sure, number one, that any students that I'm working with are considered collaborators and co-authors and colleagues in the work that we do, but also that I take the time to explain this is why we're doing this, or this is the significance of that, because this is a learning experience. This is not just about having someone to help do lit reviews in order to get papers out. This is a meaningful learning experience for students, whether they are graduate assistants or not. And I feel it's a responsibility to provide that learning experience even as we are doing the work. And it's important to me to do that because someone did that for me. Someone opened up doors for me to be able to learn and get that expertise and build my ability and my confidence in my ability to go out and do this as an independent scholar. And so for me, in my relationship with working with Ms. Jules, it is vital that whenever we are doing data analysis, we're talking about, well, here's why we take this approach to analyzing the data. Here's why we don't just jump into answering the research questions first, but rather let's actually dig in and explore what the data are telling us, because we may end up having to go in some different directions. That whole process of learning and discovery is at the core of the ways in which I like to work with students, because I want them to come out of it with tangible skills that will benefit them as they move forward, because they're going to be my and our colleagues at the end of the day. Dr. Telfair, you're muted.
You think I would know this by now, right? Okay, Sanctum Sanctorium. All right, much appreciated. All right then. So first of all, before I get there's a lot of comments for y'all in the chat, so please see those. So let's start with our faculty. So Dr. Palacios.
Dr. Smallwood and Ms. Jules, what an inspiring presentation. It is really rare to see something as well put as you were able to deliver your message today. Thank you so much. I, as a new faculty, have a question to both. I do community engaged research. How has that engagement between, the contacts you have in the community and your relationship, mentor-mentee relationship, how was that done, especially in your topic, which is, around a very sensitive private information? I cannot stress enough how amazing the research you guys doing is, and I would love to learn from you guys.
Thank you for that question, Dr. Palacios. I'll go quickly, and then I want Ms. Jules to weigh in. But I will say it has been challenging in this particular environment, because Ms. Jules came into my community engaged work at a time when it has been extremely difficult to do community engaged work, right? So Tanya came in 2020, right, at the beginning of the pandemic, and we're still recovering with trying to figure out like how we move forward. And so, I am so thankful for Ms. Jules' ability to adapt, because I wanted to be like, okay, we need to go out. Let me show you all the community partners. Let's go, let me let you talk to the people. But we had to do everything via Zoom. And so what we have ended up doing was basically leveraging a lot of the relationships that we have digitally in order to build those relationships. But also, Ms. Jules has also been very proactive in reaching out and getting engaged with community organizations, not just the ones in our HIV work, but also with the ones that pertain to her research interests as well, and her community interests. So I'll stop there.
That's definitely, I'll agree with Dr. Smallwood. It's been, we've been overcoming barriers of COVID, but doing it in a very successful way, I'll say. And we found other avenues to continue to engage with the community, which has allowed us to continue the work, again, in our respective interests, but also within the realm of HIV. but really utilizing during COVID times the virtual aspect of things. But it's been really amazing working with Dr. Smallwood and maintaining these connections with individuals virtually, even throughout the pandemic. You know, meetings that would be at 6, 7, 8, 9 p.m. Or really early in the morning. And if I was around, you know, being able to be in the background and wave and introduce myself. But it's been it's you know, overcoming barriers, regardless of it being COVID-19 or not. There's always challenges with working with the community, and working with someone that understands to meet the community where they're at, which is a value that I hold, has been amazing and really helpful in the process.
Thank you.
Thank you.
So could you share a couple of those strategies to leverage those relationships with your contacts online and digitally?
Yeah. Could you put them in the chat? Because we have one more question. So Dr. Mays.
Thank you both. This is a wonderful presentation. My question is loaded. So do you know the impact factor of this work in a peer-reviewed journal that's a top-tiered peer-reviewed journal? And the reason I ask that is I feel like two things. We train students at this program for the doctorate in public health, the DRPH, not the PhD in public health. And that applied work that you just presented, I see astronomical impact factors for communities. But I don't know that our institution and the academy values the community-based participatory research model and what you're really doing that really makes a difference, not just simply putting something in a high impact factor journal that never gets read or makes a difference. So my question for Tanya is, when you came to this program, it was a DRPH, do you feel that this program is living up to your expectations of the practice-based DRPH? My question to Dr. Smallwood is, as a faculty member in a college of public health, do you feel that colleges of public health have lost their way with regard to the primary functions of public health and promoting health of communities?
Great question, Dr. Mays.
Yeah.
I definitely.
I'm sorry, Ms. Jules, we at 1 o'clock, and I want you to answer, but I just want to let people know it's 1 o'clock. I want to thank everyone for coming, and please, we have another seminar coming up. So I will let the two of y'all finish, and if people want to hang on, absolutely wonderful. I just want to make sure we had a time check there. Go ahead, Ms. Jules. My apologies for interrupting.
No problem. Thank you. And thank you everyone for listening to us. But yes, the program, I'm not sure what I expected entering this program. I did have expectations in terms of it being a DRPH and being more practice-based heavy. I did not anticipate the, I guess, cross-pollination of it also being pretty research heavy. And that's been really helpful for me because in what I want to do moving forward, I do need to work on these tangible skills of research to actually do the practice. You know, I can't do what I'm doing without understanding what's already being done out there. I can't be innovative if I don't know what's already been done. I can't understand what gaps are in the literature unless I don't understand. And I believe working very closely with Dr. Smallwood has been given me more opportunities to engage in the practice-based work. I'm also on the Violence Prevention Task Force for Statesboro, and maybe I would have heard about that otherwise, but Dr. Smallwood was definitely my connection into doing more things in the community and bringing in the practice base outside of class assignments and preparation for a dissertation, or even some classes that allowed for some practice-based work. But it definitely, I'd say in this program, it is more of a proactive effort to ensure that you are doing all the things, which is kind of what we should be doing because my hand shouldn't really be held anyways. So, but it has been a journey.
And I will, first off, Dr. Jules, speaking into existence. Just to follow up on the second part of your question, Dr. Mace, I don't want to speak necessarily for all schools of public health or colleges of public health, but I do think for public health in general, we do need to make sure that we keep the principles of social behavioral science and the community health aspects at the forefront, because oftentimes they get, I don't want to say minimized, but they're not prioritized in the same ways as, for example, epidemiology may be prioritized, or some other aspects of our public health, various disciplines. And especially now, because so much of the work is now going clinical, it's like diffusion of innovations. You can create the greatest new thing, but if you don't have the right messaging going along with it, and you don't understand how people are going to receive it, then we're still going to be at the disadvantage, and we're still going to be exactly where we are. And so I think it's just important that we continue, using King as the drum major, right? That we continue to beat that drum to make sure that we use all the tools in our public health arsenal to bring to bear on the issues of our time. And that goes within our institutions as well as in our educational systems.
Okay, so I want to thank you both, and I just want to say amen to those last two comments, because you really don't want me to get started. So in this way, but anyway, so thank you all, and thanks everyone, and we do wish you the best of the rest of the day. We will get the slides from Ms. Tanya E. Jules. We will have the recording to go with it, and we will post it on our site. Please attend our next seminar, as an outside guest is coming. So thank you so much, Ms. Jules and Dr. Smallwood. This was fascinating, phenomenal, and so many people benefited from it. Take care of yourself.
Thank you so much.
Okay.